Good morning or good afternoon. This is Craig Field, and I'll be presenting Implementing Screening and Brief Intervention in the Trauma Care Setting. You will have an opportunity to ask questions at the end of the presentation. You can also ask questions via the interface over here. So if you prefer to write them down, I won't answer them immediately, but we'll certainly answer them at the end. And so that's how you can answer questions, ask questions. First, I wanted to let you know a little bit about why I'm doing this presentation. About 4 years ago, I moved to the University Medical Center at Brackenridge in Austin, Texas. At that time, they were a level 2 trauma center, and they wanted to become a level 1 trauma center. And as a part of that package, they wanted to develop a screening and brief intervention program that was a model program. And because they were transitioning from a level 2 to a level 1, they had the resources to be able to do that. And so I moved down after completing one of the first studies of brief interventions for alcohol use. Recently completed a second study regarding brief interventions for alcohol use, and I'm currently conducting a study of brief interventions for drug use. So you may have noticed in the title that it focuses on trauma centers. If you are from a trauma center, you are probably here because you are familiar with the Resources for Optimal Care of the Injured Patient, which was released in 2006 and indicated that all level 1 and 2 trauma centers needed to have a mechanism, they needed to have a way to identify patients, injured patients, who were problem drinkers. And for level 1 trauma centers, they not only needed a way to identify patients who had problem drinking, but they also needed a way to provide intervention, brief interventions, or referral for patients that had been identified as problem drinkers. And so while my presentation will focus on the context of trauma centers, it's not entirely limited to trauma centers. If you work outside the trauma setting, if you work in inpatient hospital settings, if you work in primary care settings, almost all of the information that I'll be presenting today is equally applicable in those settings. And in fact, the Joint Commission is coming. They are in the process of developing parameters, metrics for evaluating hospitals' engagement in screening and brief intervention and referral for treatment activities, and are beginning to consider the value of having these as performance measures. And so these are under serious consideration and in all likelihood are likely to impact the care that's provided at hospitals in general and not just trauma centers. So it's certainly applicable to other settings. I don't want to cover the evidence base for brief intervention, but I do want to let you know that a number of professional organizations, healthcare agencies support the use of screening and brief intervention and referral for treatment. And those include the Emergency Nursing Association, the Joint Commission, Substance Abuse Mental Health Services Administration, SAMHSA, NHTSA, the U.S. Preventative Task Force, the Centers for Disease Control and Prevention, and the World Health Organization. So there is a large body of organizations and agencies that have supported the implementation of screening and brief intervention. Fortunately, you don't need to reinvent the wheel. In fact, it's my hope that through the process of this presentation, you would have a better idea of how you might implement screening and brief intervention in your trauma care setting. One of the things that I was thoughtful of when putting together this presentation was the idea of scalability, that I'm in a situation that's a luxury for many hospitals or trauma centers and have resources to put into screening and brief interventions, but not all trauma centers do, and not all trauma centers are level 1 trauma centers or urban level 1 trauma centers, and they may not have the resources to be able to do a full-scale program. And so it was my intention to provide a presentation material that would allow you to sort of dictate based on resources that you might have available to you how much you are going to be able to invest in the process. And so I try to pay attention to scalability and application across different settings. And I hope that proves to be the case. One thing that I want to mention, sort of as caveat emptor, is that while I can provide you a roadmap for successfully engaging in screening and brief intervention activities, in many ways the success of the program or the integration of the program is dependent upon your setting. It has to fit within your setting and within your context. So while I can tell you how I've done it and how others have done it, you're going to have to be innovative in the sense of how it fits in your setting, and you should feel free to have that latitude. You know your trauma center the best, you know your hospital setting the best, you know the players and the people that are involved in being able to have a successful program like this, and so I trust that you'll take those factors into account. Second thing that I would like to mention is that we can sort of think of different barriers and challenges to screening and brief intervention. Some of those barriers and challenges are design specific. They have to do with screening and brief intervention in general. So what kind of screening instrument are you going to use? Who's going to be responsible for conducting this screening? And then some of them are site specific. You know, where will the screening be done? Who will conduct, not who will conduct the brief intervention, but where will the brief intervention be conducted? Not all sites have the same resources available to them to provide an isolated setting for brief intervention. That would be really outside of the norm. So some of the challenges are design specific, and many of the things that I'll talk about today speak to the design specific challenges. But many of the challenges will be site-specific. They'll be specific to your site. And while I can kind of alert you to what those site-specific challenges might be, I'm not always in a position to be able to tell you what the best answer is. What I'll try to do is tell you how people have answered those questions and different answers that they've come up with. I don't know that there's any right way or one way to do this. I think what probably matters most is being able to successfully implement such a program with a high degree of fidelity to what we know works. So there are some common barriers and challenges that exist despite the design of the project or the site where it's implemented, and it's those things that I intend to cover quite at length. So here are some examples of design-specific and site-specific challenges, and then there are some common barriers: training, how do you get people up to speed in terms of conducting the screening and providing brief interventions, and how do you identify community resources, treatment resources that are available in your community, and what kind of care they provide. Those are fairly common barriers. And I'll try to address many of these, but I won't be able to do it entirely because of the site-specific issues that you're likely to encounter. Most of this presentation is largely based on the alcohol screening and brief intervention for trauma patients, what's commonly called the Trauma Quick Guide. It was developed by the American College of Surgeons Committee on Trauma. I've added the link to this resource there in the presentation, and you can get it yourself. But what it does is provide kind of a roadmap for questions that you might want to consider when implementing a program. And so that's sort of the foundation of this presentation. Another excellent guide that's available to everyone through the Centers for Disease Control and Prevention is a step-by-step implementation guide for trauma centers. So it sort of goes in greater depth than the quick guide itself in terms of organizational processes that need to be undertaken in order to successfully implement a screening and brief intervention. So I do want to make you aware of that resource. It's an excellent resource and has proven to be helpful to our program and trauma centers that are affiliated with us. So when you begin thinking about implementing screening and brief intervention, there's sort of a checklist that you can go through in terms of identifying questions and trying to answer them to the extent possible that you can as a single decision maker. And so those items include what I will call a strengths assessment. You need to define your target population, develop a clear practice guidelines for your hospital, develop a charting protocol, develop a billing strategy, develop a data collection and storage plan, develop quality improvement initiatives, and establish a referral network for treatment centers and other community resources that may be available to the patients that you'll come into contact with and likely talk with. And so this is a good starting place in terms of thinking about what a screening and brief intervention program ought to look like at your facility. In fact, I would encourage you to sit down and think through each one of these steps before maybe taking it to a larger group, and just think about, well, what are the different options in terms of each of these bullet points. It all sort of begins with what I would call a strengths assessment. Often this is referred to as a needs assessment, and I prefer to think of it as a strengths assessment in the sense of thinking about it in the sense of what resources does my team, does my hospital, does my trauma center have to dedicate to screening and brief intervention? What assets do we already have in place for successfully implementing a screening and brief intervention program? So you might think in terms of top-down and bottom-up support. Who are the people at the highest levels that might support this kind of program, and who are the people at the bottom level? Who are the foot soldiers that are going to be invested in the implementation of this kind of program? Is there an internal champion? Is that champion you, or is it somebody else who's kind of spirited and dedicated to successfully doing this kind of thing? It may be an injury prevention coordinator, it may be a social worker on the social work team, it may be an LCDC counselor, but try to identify somebody who's really going to maintain the momentum of the program once kind of the administrative decisions have been made. Also, what internal or external policies do we have in place that would facilitate the screening and brief intervention process? So one example of this is when I came to the University Medical Center at Brackenridge, they had already put into place the audit, the Alcohol Use Disorders Identification Test, as a screening procedure for all of their patients. They honestly weren't actively using it, but it was there. And so it was one way for us to think about screening patients that we wanted to be able to provide brief interventions for. And so that's sort of an example of what policies are already in place to sort of facilitate what we want to do. Also, what training do you already have? Are there people who have maybe been to a workshop on brief intervention? There's been many of those. Many of them are conducted by myself or Chris Dunn or other leaders in the field over the last 5 or 6 years. And so is there somebody that's been to one of those trainings where it really took, or that has training in motivational interviewing, or has training in related skills, counseling skills, that might be a valuable resource in terms of doing brief intervention? What space do you have? And another important characteristic to think through very carefully is the patient flow and patient demographics. People get overwhelmed when they think about all the trauma patients that are coming to their facility in 1 year. A fairly common number is 1,500. Not all of those patients will you be able to speak to, as you well know. And I would say on average that you'll be able to speak to about 80% of them. So that's 1,200. Of those 1,200, you should be able to screen a large majority of them. So again, let's presume 80%. That would be about 800. That would be about 960. I'm going off the top of my head, so I may be a little off. So we're down to 960 patients from the 1,500 patients in terms of who we are likely to come into contact with. About 40% of those are going to be positive for alcohol problems. So that's about 400 people. Some of those you won't be able to talk to. They'll be discharged prior to you being able to see them, or they'll be discharged at a time where you don't have staff on board. I don't know. There probably is one or two, but there are a few programs that are staffed 24/7, and so these kinds of near misses are likely to happen. So you won't be able to talk to all 400 of those, but you'll likely be able to talk to 300 or 350. If you think about it, that's about one patient per day. It's not overwhelming. And so often people start with 1,500 with an overwhelming number, but when you begin to whittle it down, it's a pretty small number of patients. And so if those procedures can be put into place in an efficient manner, then the program can take place with a relatively small footprint on the program overall. And then what technologies, if any, do you have to sort of facilitate the process? Electronic medical records is certainly one example of that. But your first step is really to get buy-in at all levels, and these include an administrative level, a clinical level, and a business level. And so I really recommend that you develop what I would call an elevator talk for each of these target populations, because they're each going to have their own interest and concerns about a screening and brief intervention program. And you'll need to be able to speak to those, and speak to those rather rapidly. If you come to a clinician with a business case, it's probably going to fall on deaf ears. And so you need to be fairly aware and alert of what it is that certain people are concerned about or have questions about, so that you can be able to easily answer those. I've tried to provide kind of in a nutshell what those different cases might be. From an administrative case, this is something that's required. So, I mean, we can always say that, you know, the American College of Surgeons requires that level 1 trauma centers provide brief screening and brief intervention. Recently, I've been telling people about the Joint Commission requirement that's coming up, and the other organizations and agencies that support screening and brief intervention. So that's one element of an administrative case. Joint Commission seems to be particularly compelling. The clinical case is that there are really scores of studies on the efficacy of screening and brief intervention, and I would encourage you to find 2 or 3 bullet points. Unfortunately, I wish I had put those in here. I think in an effort not to attend to the facts or the research, I may not have done that. But, you know, some key findings are that for every 9 interventions conducted, 1 DWI arrest is prevented. That in general, we can reduce the risk of injury, we can reduce the alcohol intake, the alcohol problems, we can increase referral for treatment. Those are the kind of benefits that are seen from brief intervention. Finally is the business case, and there are a number of cost-effectiveness studies that reliably indicate that for every dollar spent, there is about $4 saved. There's at least 2 or 3 cost-effectiveness studies that have shown a number around here, and that has to do with healthcare cost as well as cost to the community, like subsequent arrest and readmissions. It's been looked at a number of different ways, and I think it's fairly confident saying that $4 is saved for every dollar spent. And if you apply that throughout all the trauma centers, just the trauma centers in the United States, approximately $1.5 billion in healthcare costs would be saved with the widespread implementation of screening and brief intervention. So it comes at a large benefit to the hospital. In thinking about who it is that you need to talk to, I like to put people in one of 4 categories. Those who are in high power and low interest, those in high power and high interest, those with low power and low interest, and those with low power and high interest. And sort of think through who is it that is in each of these categories. And I'll try and give examples of who is commonly in those categories. In terms of a high power, low interest, these are people from the legal department. So they have quite a bit of input in terms of some of the questions that are come up that I'll address here in a few moments. The CEO of the hospital, people like the medical director. These are all people who are in powerful positions to say yay or nay. If they veto it, it's going to be hard to overcome that. But they're relatively low interest, so you need to gain their approval and acceptance, but probably not expect that they're going to be actively engaged in the process of implementation. But basically, this is anyone who would have the power to make policy or change, but might not have a specific interest in doing so. The next is a low power, low interest person. This would be somebody like medical records or the electronic medical records, the IT people who are overseeing electronic medical records. It's basically any department who may have some involvement but would not have power to make change or have a specific interest. So you'll certainly need their engagement, but they don't play a particularly influential role in deciding whether or how to implement a program or whether or not you can implement your program in a particular way. But it's helpful to involve them and know what the impact of your decisions are on them so that they can be addressed and taken into account. The next is a group of low power and high interest people. These are in many ways the most important people. The nursing staff, the clerical staff, licensed clinical counselor, the licensed chemical dependency counselor, the chaplain, whoever it is that's going to be involved in the conduct of screening and brief interventions. So groups which would have a great interest as it might affect them, but not necessarily any real power in decision making. So they're certainly going to be involved when it comes to time to put the rubber to the road, but they may not necessarily be involved in the early stages of the development. But you certainly want to keep them actively involved, actively informed, educated, and aware of the program activities, and let them know how things are going, basically. Then you have a group of high power and high interest people, those who are immediately responsible for, in this case, those group of people who are immediately responsible, for example, for the care of trauma patients. People like the trauma medical director, the trauma coordinator, director of nursing, and other people who are going to be in a day-to-day position of helping make this happen. So obviously this is a very critical group of people to involve. And so that's one way, that's one framework of thinking about who is it that I need to talk to at my facility about this program? Who can provide input? Who's going to have influence over the process? And who's going to carry out the process, and how I keep them engaged? So one of the things that I pulled from the implementation guide from the CDC was this support planning tool, where we identify people who are of interest that you will almost always need to talk to, and sort of identifying them, who's going to talk to those people, what is it they're going to present to those people, when in the process are they going to do that. We're going to go to overall administration first, or work out some of the kinks at the billing and legal level. But this is a good roadmap in terms of thinking through at your hospital who those people are in the four squares of the table. So now I want to go one by one through the ACS recommendations, and these are from the quick guide, and this is what I mean earlier when I mentioned the quick guide and how it structured this presentation. These are the questions that are presented in that quick guide. How are patients identified? Who provides the brief intervention? What training has been provided? How is SBIRT, screening and brief intervention, documented? How's productivity tracked? How are confidentiality and liability managed? And what is the reimbursement strategies? These are all questions that the quick guide outlines in terms of thinking through the development of screening and brief intervention at your facility. So let's take the target population first. Which patients will you be screening? Will you be using a universal or a targeted screening approach? So a universal approach would be universal, and you would screen all patients that come through regardless of their characteristics. You may decide for whatever reason that you want to do a targeted screening approach. So for example, you only want to screen adults, people over the age of 18, or you only want to screen people over the age of 21 who can legally consume alcohol. You may go the opposite route and say we only want to talk to people under 21. And so there's different ways that you can sort of focus the screening based on your facility's needs and the patient population. You may decide to include or not include dependent users. You may provide additional services to those who are identified as alcohol dependent, or you may decide that at the very least we're going to make sure that they receive a brief intervention, and if they need additional services, we'll certainly connect them with those services. That's one way of thinking about it. Adults versus adolescents. These are all examples of defining the target population. You might also think about which patients you'll exclude from the screening. So these might be patients with traumatic brain injuries. These might be patients, and I'm not necessarily recommending this, I'm just citing it as an example, but you may decide that the IMC is not the environment that you want to focus your limited resources on. Some decision like that in terms of who are we going to exclude from screening, but you want to have a fairly rigorous standard in terms of who's going to screen, who's going to be screened, and who's not going to be screened. I think this is critically important when it comes to the potential benefit of brief intervention. If we rely on discretionary screening, or we rely on clinical judgment, however good it may be, we're probably going to end up with a group of patients who may be less likely to benefit from brief intervention than if we took a systematic, standardized approach to screening our trauma patients. And so I do think it's very important to think through who is it among our patients that we are most interested in being able to provide brief intervention to. So here is one example of a target population. It's not the one that we use, I don't believe, but it is certainly one example. So all trauma patients that meet predetermined trauma definitions. So you may say only level 1 trauma patients, not level 2 or level 3, or you may say level 1 through 3 trauma patients. All admitted trauma patients over the age of 14 who are alert and oriented or become alert and oriented during the hospital course. And so that's a very reasonable target population to identify. All patients who screen positive on some pre-screen. Have you had more than 5 drinks per occasion in the last month? Okay, then you're getting a brief intervention. But basically you just want to define standard clear rules just like you would for other trauma care or other medical care. Establish clear guidelines for who the target population is. And this is merely one example of that. Also is the screening protocol, and to think through that. What substances will you screen for? Certainly right now trauma trauma departments are requiring that we identify patients with alcohol problems and provide brief alcohol interventions. You may decide that in your trauma center, methamphetamine use is of particular concern or interest, or there are local pressures to address methamphetamine concerns, or something like that. That's a made-up scenario, but there may be pressures to screen for other substances of abuse. Or you may feel that it just makes sense for us to do all substances of abuse, and that certainly makes sense, and it's one approach. Or you may decide right now the trauma ACS requires us to do brief alcohol interventions, and we're going to do that and refine that process and then move on to other substances of abuse. We screen for mental health or other behaviors. In part, I ask this because it's helpful to think about there may already be some screening procedures in place for other health behaviors, and you can simply slot in questions about alcohol and drug use. And so that's kind of a very benign way of introducing those screening questions, benign for both the staff who have to ask the additional questions, maybe 1 to 3 questions, but also the patients as well, as who I really had in mind in terms of you're just asking them about health behaviors. You're asking them about smoking. You're already asking them about obesity or weight or diet or other health-related behaviors, diabetes management, asthma management. And so to ask a couple of questions about alcohol use is not that foreign. Who will conduct the pre-screen or the screen? Who is it that's responsible for doing this? At what point in the admission process will this be done? Make sure that somebody's responsible for it or responsible for managing it. Otherwise, it's likely to go under the radar and be lost in the shuffle. When and where will the screening be conducted? Will it be conducted in the emergency department prior to admission? Will it be conducted in once the patient is admitted to the hospital? Will it be conducted, you could say we will conduct screening 1 day after hospital admission or something to that effect to try to minimize the, increase the efficiency. How will the results of the screening be documented? And this we'll go over a little bit later as well, but it's worth considering here. Will it become a part of the patient's medical record? Will it be entered in the electronic medical records? Will it be kept separate from those records in some way, shape, or form? How and where will the screening results be documented? And that's whether a patient screens positive or a patient screens negative. And you may have 2 different ways of dealing with those different screening results. More importantly is how the results will be communicated. Often trauma centers are faced with making one of 2 decisions. Either the person that conducts the screen is also going to conduct the brief intervention, which obviously introduces some efficiencies into it because the same person is asking questions about the person's drinking and then simply going right into the brief intervention. Or you can have a process where the admissions nurse is responsible for screening, but she doesn't provide brief intervention. She alerts the social worker to conduct a brief intervention. The advantage there is that you can put people in the role that their skills are best suited to and increase kind of professional efficiency. The risk there is that there's loss in patient contact because one person is doing the screening and another person is doing a brief intervention. So instead of having it all one package done at one time, it's separated in time and it relies on communication. This is certainly not impossible to overcome, but a downside to that approach. What screening tools will you employ? Will you use blood alcohol concentration? Will you use the Alcohol Disorders Identification Test? Will you use, I guess I like BACN audit because I put them here twice. There's another measure for adolescents that are specific to adolescents called the CRAFT. You may have some combination of screening measures that you want to employ. I don't have a lot of investment in, despite the fact that BAC and audit are listed twice and it is what I use, I don't really have any investment in any particular screening tools. I think there are advantages and disadvantages to each of them. There are, thankfully enough, a large number of screening tools available to us today that have fairly good standards of being able to identify particular patient populations with alcohol problems. What I do try and focus on when I work with trauma centers is making sure that it's systematic and it's standardized, like I mentioned earlier, rather than relying on discretionary screening or rather than relying on staff referrals. So, for example, my brief intervention staff don't sit in their offices and wait for a nurse or social worker to refer a patient to them. They're actively engaging in the screening process, making sure that all patients who come through are being screened so that there's no selectivity. And in that way, we've maximized the benefit of brief intervention. And so I'm not too concerned with what screening tools you choose, just that when you do choose them, that they're put into place in a standardized and global manner. Then you need to think about the brief intervention protocol itself. Who's going to be conducting the brief intervention, which we'll talk a little bit more about in a moment. Which BI support materials will be used, and I will provide you information about that. Which patient handouts will be used? I'll give you an example of that. When and where will brief intervention be conducted? Will it be done in the emergency department? And if so, how will we manage confidentiality and privacy? How will the goals be documented? How will whatever is discussed in that brief intervention be documented? What, if any, documentation will take place with regard to the brief intervention? So, a critical question that is often asked is who can do BI? And one place that I start is with who wants to do BI or who's in the best place to do brief intervention. This varies from facility to facility, and there are different kinds of people that can do brief intervention. I'm not of the opinion that brief intervention, that, for example, only psychologists can provide brief intervention, or only surgeons can provide brief interventions, or only social workers can provide brief interventions. I've come across people from all professional backgrounds that I think are successfully able to do brief interventions, and I've come across people from all professional backgrounds who I wouldn't want doing brief intervention. And so I think it's less dictated by professional background and more by pragmatics and providing training and providing reinforcement for doing brief interventions. A number of people at a number of different facilities have been designated as the people who will be responsible for brief intervention. I don't see it here, but chaplains is one that I've heard of that I don't see here. Peer counselors, health promoters, patient navigators, those are all people who are fairly well positioned to do brief intervention. And so I guess what I would encourage you to do is not to think too narrowly about who is able to do brief interventions. When thinking about who can do brief interventions, you might want to take into account people's knowledge and experience of substance abuse problems. Honestly, a lot of knowledge and experience can sometimes be a barrier to successfully conducting brief interventions. But some knowledge and experience is helpful. And I don't want to generalize or stereotype, but there is a spectrum of knowledge and experience that I think is helpful in terms of conducting brief interventions. A big one is just interpersonal skills, the ability to be non-judgmental, to have conversations with patients around difficult or uncomfortable topics like alcohol use. And so if you know your staff well, you know who it is that's able to do that with some finesse and aplomb. Willingness to take on responsibility. So obviously that's important. It's important to have somebody who's going to take ownership of this activity, embrace it, not see it as something that's cumbersome, but seeing it as something that's added value to their professional development. And also some flexibility in work schedule. Oftentimes the staff who are maybe best positioned to do brief intervention are overtaxed with other activities, and so you have to find a way to help them manage that in a way that they can continue to be successful at both responsibilities, the previous responsibility and responsibility of conducting brief intervention. So I want to talk a little bit about training in brief intervention. It's worth mentioning that there are really few standards regarding effective training of brief intervention, particularly for healthcare providers. What we can say with some degree of confidence is that a workshop is probably insufficient and that some level of ongoing training, supervision, monitoring, peer discussion is probably going to be essential in terms of continuing to develop, refine, and maintain these skills. But we really don't know a lot from a research perspective about how training in brief intervention is effectively provided. But most trainings last about 8 hours. They include didactic material, modeling and examples, video examples, and most importantly practicing and hopefully sort of establishing some sort of goal or plan for providing brief intervention. So a typical model a training model that Chris Dunn and I have sort of settled into over time, I think, is to have 1 8-hour training, and that can be broken up into 2 4-hour sessions where we cover the mechanics of brief intervention. We will do a tell, see, do is basically the approach we use. We tell people what the different pieces of brief intervention are. We show them what that looks like, and we ask them to practice that. And we go through each of the 3 pieces of brief intervention, and then by the end of the day we put the whole brief intervention together. And then when folks leave, they have a plan for how it is that they're going to continue, what skills they think they need to work on, what comes easily, what seems more difficult, what are they going to focus on. And then we ask participants to commit to trying brief intervention on 2 or 3 patients. And then a week or 2 later, we'll come back for another 4-hour session, and we'll refresh on the brief intervention model, and we'll go through the clinical experiences that people have had with brief intervention. And this seems to be a very effective model in terms of training folks in brief intervention. One of the grant proposals that our team has submitted is to evaluate different training methods for brief intervention in the healthcare setting. So different ways that we might go about training healthcare providers in brief interventions. And what we've done is try to strike a balance between what is known to work with other interventions by other providers and what's really practical in a medical setting. So that's one exciting proposal that we're working on. There are a number of SBI training resources. Here's a list of some websites that are available and have some materials on them. The ENA has put together an excellent program training materials for screening and brief intervention. SAMHSA has developed similar programs. Insurance Solutions joined together. Those are other websites that are out there that have quite a wealth of information regarding brief intervention, how it's done, and different things to take into account. The motivationalinterview.org website is a place that you can go to identify training opportunities. You may have a designated staff member who is particularly interested in learning and mastering brief intervention based on motivational interviewing, and so there are definitely training opportunities that are available to them, and so that's one place to find those. Really, over the last 5 years or so, the wealth of information in terms of information for patients and information for providers and tools for conducting brief intervention have just really exploded. So I don't think you'll have a difficult time finding materials. Here are 2 guides and a patient handout that I think are helpful. There are certainly others that are equally helpful. I don't mean to exclude those. I just wanted to provide you an example of 2 that I think are particularly helpful. Excuse me. And I provided the websites for those. The first is Helping Patients Who Drink Too Much, which is a clinician's guide. When it says clinician, I think it means, broadly speaking, it could be a nurse, it could be a physician. I think it's targeted towards physician, but it really could be anybody that's providing medical care to the patient. And this provides kind of a 1, 2, 3 roadmap for identifying patients and providing brief intervention. And then in the last year or so, the National Institutes of Health, National Institute on Alcohol Abuse and Alcoholism, has developed a patient handout, patient materials called Rethinking Your Drinking, which I think is an excellent match for brief intervention and the overall message and method of interacting with patients around their alcohol use. I just think it's very consistent with what we're trying to achieve when we conduct a brief intervention. And I think it's patient friendly. Patients appreciate it. There's always something for a heavy drinker. There's always something in that book that's helpful that you can sort of point to and say, you might look at this, you might look at that. So for example, you said you were interested in cutting down on your drinking. Here's some guidelines about how much is too much. Another patient might say, I'm gonna watch my drinking. And so there's a nice page in there that has a little calendar that they can write on, and so sometimes we'll point the patient to that and say, you mentioned you were going to watch your drinking and pay attention to it and see what it's like, get a better sense of what it's like, and here's a tool that you can use to do that, to sort of keep track of your drinking and look back on it and evaluate kind of where you're at. So there's lots of helpful information that really covers the spectrum of patients' readiness to change. So another issue is documentation. Where will the chart note be kept? Will it be kept in the main medical record? Will it be kept in locked files? So paper documentation kept in the patient record or the electronic medical record? Will it be kept separate from the medical record? What information will be included related to screening and or brief intervention, and just basically determine the flow of information, the paperwork, and data. I think I have here. So here is what our team writes in a chart, and I'm not suggesting that you take it verbatim. I'm just wanting to let you know what we write in our charts. It's trauma services, behavioral health services, screen patient for injury-related risk behaviors, i.e. drinking, social worker provided a brief intervention targeting injury prevention practices, i.e. reduced drinking or reduced engagement in risk-related behaviors such as drinking and driving. This last sentence may or may not be there. Crisis hotline and general resource listing provided to patient. Actually, we always provide a resource listing to patients, so a statement like that would be in the documentation. But basically, that is the extent of the documentation, and it is largely intended to convey to other staff members that a staff member from our program has talked with the patient about their drinking and drinking-related risk behaviors, things that might put them back into the hospital for another injury. We We avoid labeling patients because we only screen them, and so we can't diagnose them on the basis of that. And our attitude has been to not add any information about their substance abuse to the chart. In all likelihood, it's in other places, but we don't like to add to it. And in part, that has to do with the fact that we are identifying at-risk drinkers. So these are not necessarily alcohol-dependent patients, and any information that might suggest that might do some harm to the patient, and so we don't like to stigmatize their drinking because we feel like it might be misinterpreted by future healthcare providers or insurance companies or other people. Monitoring and evaluation. So who will monitor and report SBI productivity, screening and brief intervention productivity? Who is collecting the trauma data? And what will be reported and to whom? So typical things that we track, and I recommend that trauma centers track, are the percent of all patients eligible to be screened. So who is it among the admissions, who's among the admissions, and based on the parameters that you've set for screening, how many of your patients are eligible for being screened? And then among those that were eligible to be screened, how many were actually screened? And then of those who were actually screened, how many screened positive? And then among those who screened positive, how many received a brief intervention? I think those are 4 key pieces of information that every trauma center who is providing screening and brief intervention ought to be keeping track of, if not for somebody else, for their own, for the health of their own, health and development of their own program. Here's a screenshot of what we have included in our trauma registry. So we have modified the trauma registry. I think everybody's able to do that to a certain extent. And so we've added this page to collect information about substance use, screening, and brief intervention, and any follow-up that we may have done with a particular patient. And so that's sort of how we keep track of, that's one way in which we keep track of our activities. We've also developed this dashboard, which we periodically report to the Performance Improvement Committee. And so we just let them know basically how our activities are going, how many patients are screening positive, how many patients are screening negative, how many patients are being provided brief interventions. And we present that to the Performance Improvement Committee, and it's often discussed. And so I notice on this particular one, I'm not showing you a golden one by any means, we actually have a high number of discharge prior to being screened and weekend admissions. And so 2 things that have come out of this is making sure that we're part of the discharge, a formal part of the discharge process, so that those patients who are screening positive for alcohol problems and there's someone there to provide brief intervention, that they're receiving that brief intervention. So that was a very unusual number of discharge prior to brief intervention for us. And there were some systematic changes that had happened to influence that number. And so that was brought up in the performance improvement meeting and discussed. And then we have a high number of weekend. And again, this is an unusual number of misses for the weekend. So we operate predominantly on normal business hours, which over the last 4 years has not proven to be a great loss in terms of brief interventions. We've tried different time periods, working in the evenings, working on the weekends, and 40 hours is 40 hours, kind of almost wherever you put it. But in this particular report, this particular month's report, we had quite a few on the weekend, and so the conversation that brought up is sort of what is our standard, or what's acceptable? What are acceptable losses for us? And then at the bottom of the chart, you can see those 4 data points that I mentioned previously. and we compare the current month to prior fiscal year, and what we're looking at there is the percentage of patients screened. You can see that we successfully screen almost all of our patients who are eligible to be screened. UDS is urine drug screen drawn. That's the percentage of patients who have that done. That's a percentage of patients that have BACs drawn. 60% is kind of the best that we've gotten it, and I've worked at 3 different trauma centers, and honestly, 2/3 is the best I've ever seen it. I think there's probably some systematic or clinical reasons for why it doesn't get much higher than that, but that's the case, and it's very helpful for us because from a program perspective, where we want to concentrate our efforts are on providing brief interventions and not screenings. And so when a surgeon draws a UDS and draws a BAC, that gives us immediate actionable information that we can decide whether or not a patient is going to benefit from brief intervention or not. And then we have the percentage of brief interventions that are provided. You can actually see that in the last month that had gone up from the previous year. But this is a way that we sort of monitor our performance, report our performance and the program activities, and keep other people engaged in the process. Just yesterday, I'm happy to say that we had an abstract for best practices that was submitted to the Trauma Center Association of America that was accepted based on this information here. In the dashboard, we had decided to bring in a social work practicum student, and she did telephone follow-ups with the patients. So essentially, we implemented a program evaluation for a short period of time. And while that was not without its challenges, and certainly could have done a better job if we had, hundreds of thousands of dollars to throw at it, the results were very promising. And I was very skeptical of kind of what we would find. But we have found very promisingly that the patients who received a brief motivational interviewing were less likely to drink and less likely to engage in heavy drinking. Specifically, those who received brief motivational intervention were almost 4 times more likely to abstain from drinking and 29% less likely to engage in at-risk drinking. And so we were quite impressed by that. We submitted that for an abstract. And so that's a natural byproduct of the activities that we engage in. And I believe we're going to prepare this for publication in the Journal of Trauma and Nursing and really focus on the practical aspects. In addition, I provide an annual report to administrators about the program activities and the potential impact of it. One thing that I've done that has been very well received despite its potential limitations is I have translated the findings from previous studies and based on the number of interventions that we provide at our hospital, what the potential measurable impact is on our patient population. And so you can see here that based on the evidence, we probably prevented 59 arrests for driving while intoxicated in the last 3 years, 26 readmissions for treatment of traumatic injury, totaling $378,000 in healthcare costs that should be avoided, and even a very conservative estimate was that $250,000 would be avoided, which is well above the program cost to them. And so that's something that's been very well received by our administrators and has proven to be a feather in our cap, something that they really pay attention to. So the ACS, going back to the ACS recommendations that are presented in the quick guide, here are the 7 key questions that you should think about. I've tried to provide, touched on each of these and tried to provide some guidance. If you have questions, please do feel free to ask. I'm happy to answer those. Here's an example flow chart. So this is a common means of communicating medical processes in medical settings. And so here you can see that an inpatient master social worker designee completes the audit, the alcohol use disorders identification tests, which is the screening, or the ED MSW completes the audit here. Both inpatients and ED patients are being screened. It basically provides a flowchart of the program activities and how they'll be completed and what happens, all the way from screening the patient here up at the top to auditing the program performance, getting it to the trauma office so that it can be entered in the trauma registry. And so now just a quick couple of points, common barriers to implementation or concerns that people often have, and information that people come across that they're not quite sure about how it fits into brief intervention. I'm going to tell you about these things, and I'll tell you about how we've managed them in our trauma setting. I'm not suggesting that it is the truth or the way, but it's one way, and I feel like we've thought through it quite carefully with a number of key stakeholders and decision makers, and come to reached an organizational decision about how these different policies will be managed. But I do want you to be aware of them as you move forward in your efforts to implement screening and brief intervention. The first is legal issues. If I'm not mistaken, I tried to update this information. In 38 states, insurance may refuse to pay if an injury is alcohol or drug related. There are also patient confidentiality issues, which you should consult with your legal department on. Federal law 42 CFR is probably the applicable law that people often see and get confused by in terms of how it fits into the context of their efforts. Excuse me. But I'll cover those in greater detail in one by one. So first, what's commonly referred to as the UPPL, or the Uniform Accident and Sickness Policy Provision Law. Basically, it states that the insurer shall not be liable for any loss sustained in consequence of the insured being intoxicated or under the influence of any narcotic. So you can see that that's a fairly global statement. It's fairly unusual in the sense of health behaviors that might limit coverage based on insurance. And it does, in my opinion, it comes into play not very often. It does not very often come into play. It doesn't happen very often, but when it happens, it's very high impact, and so people are very concerned about this. There are efforts to change that law. It's an antiquated law. It certainly doesn't fit with our current paradigm of addressing the public health concerns of alcohol problems, and may compete with brief intervention activities. But there's also, knowledge can also help you sort of disarm its potential impact at your facility. And here are ways in which the UPPL has a number of unintended consequences in the sense of increased cost and gets in the way of law enforcement and other things like that. So it's probably doing more harm than good. It was created in 1947, and at this point, like I say, it's probably doing more harm than good. What we have taken on at our trauma facility, and I know at other facilities they've adopted a similar approach. I mentioned this in light of the documentation for screening and brief intervention. And basically, we leave BACs and toxicology screens in the chart. They have other medical purposes, and so we leave them there. We don't highlight them. We don't draw attention to them. We don't repeat them over and over again. They're there, and they're there. We keep the intervention notes in a separate locked files. Unfortunately, one of the slides that I had that was removed was an access database that Catherine Hauk, the clinical social worker at our program, we put together basically a clinical notes page. where she writes down particular data elements from the intervention about the interaction with the patient. Now, this does not end up in the medical records. It is their program records, and they allow me or her to look back and see what was an interaction like with a patient, so that, say, John Smith, 6 months from now, unfortunately ends up back in the hospital for an alcohol-related incident. I can go back and look and see, what did we talk about with John Smith? Or if, God forbid, if there's some other reason for someone to be aware of the specifics of what happened in an intervention, that information is available, but it's kept separately. It sort of have different rules about access to it, and there would certainly need to be particular needs for anybody outside of the program to be able to access that information. And that is as intended, and it is as agreed upon by the trauma department, the hospital at large, and administrators, legal department, and such. We do require a separate release of information for that information, so someone would have to specifically request that information in order to obtain it. It's not covered under the global release of information for a medical chart. And that's a function of conversations with both the legal department and medical records, and more recently has involved electronic medical records. I'm sorry, this slide is misplaced and probably should have appeared previously. But this is the current status of the UPPL. It's the most up-to-date information I could find on the UPPL by state. And it indicates in green where UPPL has been repealed, is basically no longer in effect, and other states where the UPPL still remains on the statute. There's really very little information that I've seen on the number of times that insurance has been denied as a result of the UPPL. I do occasionally hear of incidences where that happened, and it's prudent to say that when it does happen, it's fairly high impact, but it doesn't happen very often to the best of my knowledge. The other legal concerns that questions or legal concerns that come up, and I guess it's worth mentioning at this point that I'm not a lawyer. I'm simply advising you of two key policies that are in place that you will hear about that may affect your thinking about brief intervention, and so I want you to be aware of them as much as possible, and also wanted to let you know how we've decided to deal with them for better or worse. So 42 FR states in yellow, I've highlighted the key points. Records of the identity, diagnosis, prognosis, or treatment of any patient which are maintained in connection with the performance of any program or activity relating to alcoholism or alcohol abuse, education, training, treatment, rehabilitation, or research shall be confidential. So, based on conversations with our legal department, they decided that our screening and brief intervention program fell under 42 CFR and could be kept under different records and could be sequestered as a separate part of the medical records and could avoid being released under an umbrella release of information, or could be blanking on the term, but we could be mandated to give up that information. And basically the legal department looked the 42 CFR over, talked with us about our program activities, decided that it fit the bill, and that they were willing to go to bat for us if an incident should ever arise. An incident has never arisen, but we have that agreement and understanding, and so that's helpful. Your facility may decide against it. Your legal department may look at this and conceptualize it very differently than ours did, but that's what ours did. The final thing, the final development that is currently in place is billing for screening and brief intervention. There are CMS authorized HCPCS codes to reimburse for SBI. CMS has also authorized 2 new G codes to reimburse for SBI, and the AMA has authorized the use of CPT codes. So there are codes in existence to bill for screening and brief intervention, and here are those specific codes. Currently at our facility, we do bill for these activities. We do not, to the best of my knowledge, we have not been able to actually get that money, but it has proven to be an important indicator of program activity and program impact, and certainly makes a strong business case for our program. But I want you to be aware of those billing codes, talk to your medical records or billing department about them, and see if you can't begin to at least use the codes, if not be reimbursed. We're in Texas, and so there are probably other states that are more lenient and have approved these codes, put these codes into action, and will reimburse for them. So that's going to vary by state, and I encourage you to talk to your billing department about that and begin to explore that option. There are a number of health plans that cover SBI. Some very large nationwide health programs do cover screening and brief intervention. Here are some critical questions that you might be able to use to talk with your billing department about these codes and how they can be appropriately used in your facility. I just provide them here as a way to give you a starting place for thinking about and having conversations with your billing department about them. The final comments that I just want to make is that you really are, as trauma care providers or hospital administrators, decision makers, you are in a critical and pivotal role in terms of advocating for screening and brief intervention and its utility. There really is a shift in thinking about the way that alcohol problems and substance abuse problems are being addressed, particularly within the healthcare context, and in many ways your presence here indicates that you are at the cutting edge of that and are a part of reaching the tipping point for widespread implementation of similar programs, not only for alcohol problems but other behavioral health issues, and that these things are taking place, they're growing, and they will have a huge impact, are having a huge impact. There are significant changes that have taken place over the last 5 to 10 years, and I anticipate that will continue to grow and change and develop as more people like yourself begin to actively engage in these programs, and we begin to talk to one another and dialogue and find better ways to do what we're doing now. It is worth mentioning that the return on investment in terms of health interventions for screening and brief intervention is very high. In terms of the bang for your buck, screening and brief intervention rates right up there with smoking cessation. It ranks right up there with having men over 40 and women over 50 take aspirin. And so it ranks very high in terms of public health interventions that can be engaged in the healthcare setting. I think that's very promising and very indicative of the importance of the activities that we're undertaking here. And I would draw on the analogy to the aspirin effect in terms of what it is that we anticipate to come out of screening and brief intervention activities. Historically, what we've wanted to push for and see in terms of treatment for substance abuse problems is just that. We provide treatment for the most severe cases. We throw a lot of resources at a very small group of people with very severe problems who are not necessarily responsible for the large majority of alcohol problems that impact medical care and the community at large. And this provides a paradigm, it provides a way to begin to address the public health impact, and rather than having a large treatment effect among a small group of people, we can begin to have a small treatment effect among a very large group of people, and by way of doing that have an impact, public health impact on the impact of alcohol abuse in our society. And it would really be my hope that drinking becomes a vital sign, that it becomes just like blood pressure or weight or BMI. Whenever you go to the physician, he takes your weight. And that's the case whether you saw him 2 weeks ago, 6 months ago, 3 years ago. Whenever you see him, he takes your weight. No questions asked, and you sort of can't get out of it. And I would really very much like to see, I think our healthcare system would improve vastly if drinking became a vital sign and became a topic of conversation that we have with patients who are engaging in at-risk drinking. And so really substance use is a public health problem, and screening and brief intervention is a way to effectively deal with that problem. Again, you're at the cutting edge of implementing these programs. Your engagement and participation in the webinar clearly indicate that, and I hope that you'll have questions, and more importantly that I'll have answers, but that we can continue to engage in a meaningful dialogue about implementation of these programs such that in 5 or 10 years they are widespread, very easy to implement, and have a greater impact. And so that's my hope. I hope that this presentation has made some small step towards that endeavor. And so at this time I'll take questions and we'll begin.
Thank you so much, Craig.